The topic of this course focuses on post-resuscitation care. So we're going to look at those who've had a cardiac arrest and you managed to get ROS back. So the plan is to cover some of the core concepts, and really after the core concepts, we'll focus on 2 cases and use those cases to reinforce the learning, but also to bring in some different new ideas that might differ between medical cardiac arrest post-management and from the pediatric trauma patient. And at the end, we'll hopefully leave between 5 and 10 minutes for a panel discussion. Now, as mentioned in previous talks, it's impossible to cover everything in a 20-minute period. So if you have a question that I haven't answered, or there's a topic you want a little bit more information on, please stick it into the chat function and we will happily discuss it in greater detail. So I am an emergency physician, so my viewpoint is different from the ICU colleagues. So Costas last year done an excellent talk on post-resuscitative care when the patient arrives into the PICU environment. There's a huge amount of information there in terms of pharmacodynamics, pharmacokinetics, and generally he's an excellent public speaker. So to augment this talk, I'd highly recommend you reviewing some of the information that's shared here. Probably important to start off that APLS and most of our resuscitation guidelines end almost with ROSC as the endpoint. And that's not necessarily the case. It's not a time for which we all lean over the table, high-five each other and congratulate each other for doing an amazing resuscitation. That time must come later on. You must recognize that patient in front of you will still be the sickest patient you see that day, that week, that month, and potentially that year. And if you get too carried away with the fact that you got a rhythm and a pulse back, you're going to let time lapse, which is key in order to try and improve survival for these patients. So in a way, the way I think of it, that this is almost a second resuscitation. I park everything that I've done before and I start focusing my team and my leadership skills for this post-resuscitation care. And as part of the team, as the team leader, I want people to know what my aims are. And we must recognize that just as we vary from team members in terms of seniority and experience, the outcomes will be different. And the junior members of the team may only be aiming for being involved in a pediatric resuscitation or getting the patient stabilized to be ready for transfer. But as the senior members of the teams, a little bit more experience, our aim is to try and get the patient to survive with good neurological outcome. And everything we do should be for that aim. And the Resus Council says this really nicely. So we want to return the patient to a state of normal cerebral function to establish and maintain a stable cardiac rhythm and normal hemodynamic function. So essentially look after the head, the heart, and then the rest of the body. And although it's not meant to be addressed in that area, I think if you followed that direction of travel, you probably won't go too far wrong. Recognize that our role is one of a longer part of the chain of survival. And this is a really nice graph that comes from the American Heart Foundation. But what we do in the emergency medicine and what we do when we send them to the PIC unit is part of the rehabilitation process afterwards. And we are not able to do anything about those cases if there's not good pre-hospital care, either from the pre-hospital medical team or from bystanders initiating CPR and recognizing that patient has collapsed. There's a variety of different studies you can look at, and I think it's worthwhile recognizing that cardiac arrest is not what you see in the movies where you get 100% survival after putting a few pads on and doing some chest compressions. The outcomes are much worse than this. So for pediatric cardiac arrest, we're expecting about 20% to get ROSC. And this varies depending on the study, but there's a really nice one published in 2016 from North American data, which quotes around about 20% figure is what you'd expect. Of all the ones who arrest, we get about 10% discharge, and 1 or 2% will have no neurological insult, which is slightly different than good neurological function because that varies, but 1 to 2% of them won't have this insult. And this really hasn't changed over the last 10 years. Really nice paper in February 2024 will make us kind of change what we're thinking about this. So this is a Scandinavian paper from Sweden, which looked over a 30-year time period at their survival rates for the under 30s. So we take you to the middle graph. I want you to focus on that blue line where you can see it peaks at 32%. So this is 32% survival at 30 days after cardiac arrest in the 1 to 5-year-olds. And this is a massive increase from single figures. And this is really replicated through lots of different age ranges. The next graph is what the rationale that they're showing for this. So again, focus on the blue line. What they're able to say, if the graph goes back a little bit, that their mean time to initiate in CPR was 14 minutes, and this has decreased to 2 minutes. which is absolutely phenomenal if you think of that time difference. So from a child collapsing to be recognised in cardiac arrest to a bystander starting CPR, they've managed to get 12 minutes off that time. UK data would say that about 70% of all cardiac arrest, somebody attempts to some form of resuscitation, and about less than 20% will get a defib. And they really praise a huge educational drive throughout their entire society for promoting this. And I think if we're looking at how we can improve the survival rates for these children, then this data really is fantastic. So the key aims from my point of view when I'm leading resuscitation is that I want to stabilize, optimize, and package that patient. So stabilize and optimize means that I'm thinking that individual patient. I want them having to be stable as possible to have the best chance of survival. And then packaging is for two real reasons. The first one being that I want that patient ready to move so that they can get to definitive care and management. The secondary reason is that in my emergency department, I can have up to 60 or 70 kids waiting to be seen or lying in some form of illness. A cardiac arrest has the ability to suck in a huge amount of the resources in my department, and I need to start to redeploy them as quickly as possible. So my goal is to have the patient packaged and ready to go when the resuscitation or when the transport team arrives, so that we can minimize the time for them to move on to definitive care. I'm also thinking about my staff and for simple things about breaking. At all times, I have to think about the family and parents, if they've been involved in resuscitation, if they've been in the room, how to support them, and simple things. If the ambulance cannot take them to the tertiary centre they're going for ongoing care, how am I going to organise transport for them? If we look at post-cardiac arrest management advice, it falls into four key areas. So post-cardiac brain injury, myocardial dysfunction, systemic ischemia and perfusion, and persistent precipitating pathophysiology. In really simple terms, because again, in ED, I like things to be kept as simple as possible: head, heart, body, and stopping the patient going back into an arrhythmia or arresting again. So post-cardiac brain injury. So for any that were children of the 90s, like most of the people are in this group, there was an excellent band called the New Radicals, and they had a tune that was "You Only Get What You Give." And the tenuous link to this is that if we're aiming for 100% oxygen, so if we give too much oxygen, essentially we get excessive free radical formation, which is a bad thing. The brain has had a period of underperfusion and starvation, and even if you have good quality CPR, cerebral blood flow will be 50% of what the body can normally generate. So there's cell death, there's accumulation of calcium, you've got a huge amount of release of inflammatory cascade, and with the excess free radical formation, you get neuronal brain damage and death, and this process can last up to potentially days, if not weeks, after that arrest. The longer the downtime, the worse the outcome will be. And in order to improve morbidity and mortality, this is something that we should be focusing on. Adult models will support excessive free radical formation when we aim for high oxygen levels, and there's very few pediatric studies, but one observational one, which would note that we're aiming for 100% as opposed to mid-90s, and there was worse outcomes. So the way in which we accommodate this is aiming for oxygen levels between 94 and 98%, and I will be interested in discussion at the end of this, because I think some of my colleagues will aim for lower levels in PICU. From my point of view, when I'm running resuscitation and somebody has literally got a rhythm back and are still incredibly unwell, I want to aim for my lower oxygen levels. But I'd be happy to hear other people's opinion on this. As mentioned in the traumatic brain injury, CO2 hasn't been maintained within normal levels. As an increase or decrease will change my cerebral blood flow, either increasing the pressure in the brain or decreasing oxygenation in already hypoxic tissue. So measure these, have a look at them, and see how you're going. Now, this stunning picture of a myocardium is to lead us on to myocardial stunning, which I know we've touched about a little bit. But for a second, think about what has happened to this heart during the arrest. So whether it's shockable or non-shockable, that heart has went through a period of sustained pressure. It's just lay there either doing nothing, or it's ended up in a terminal arrhythmia, resulting in decreased perfusion, hypoxia, and tissue damage. On top of this, you're going to have somebody that's either 80 or 100, 120 kilos putting a huge amount of force through that heart, causing damage to it. And if it is shockable, we're sticking pads on and delivering a huge amount of electricity. So that heart will be stunned after everything that it's been through. If we look at some of the data, we'll expect to see this in between 50 and 80% of patients, and it can peak around about 8 hours after the injury, but can present straight away and can last that for 2 to 3 days. For a lot of these patients afterwards, we'll expect them to be hypotensive, and this is due to systemic vasoconstriction, as well as just having a huge amount of inflammatory cascade that's still going around the body. So we need to think about the heart, and we really want to avoid hypotension. And if you look at the therapeutic cooling trial, post-cardiac arrest, they would identify about 25% of the population will end up having low blood pressure in the first hour, associated with poor outcomes, and less than half of these got any vasoactive agents in place. Part of us is probably concerned of the fact that the heart has went through a huge period of instability. We don't want to overflow it, and we don't want to overstimulate it. But as Chris talked about rightly, that heart is at high risk of re-arresting, and we need to put something in place. So avoid hypotension, know the blood pressure parameters, and certainly don't be accepting anything less than the 5th, and you're probably aiming closer towards the 50th for these. If you need to use fluid and vasoactive agents, do so, but use the minimum amount possible in order to get your blood pressure to where you want it to be. So systemic ischemia and reperfusion. And the reason I put the sepsis 6 up here is that the cascade or the pathophysiology is very, very similar. So we've got tissues that have been hypoxic, who have got no blood flow, and they suddenly got these massive increase in inflammatory cascade. You think of a huge amount of adrenaline going on your body, cortisol, you've got instability in terms of your glucose. So a lot of these kids will have high glucose afterwards. You will get cardiac dysfunction as a consequence of all these, which will make your hypotension a lot worse. And you've got an activation and inhibition of your coagulation pathway, which may put these patients into DIC and increased risk of clotting or bleeding. And things that we need to think about is for these children is what temperature we are aiming for. So how are we managing these kids? And this has been talked about throughout the day. I've talked about the dangers of hyperthermia. If you increase the temperature even by 1 degree, you're massively increasing the metabolic requirements of that tissue. The tissue is already on the verge of viability to do so will result in an increase in necrosis. So stop your temperature rising and actively cool. We would also say avoid hypothermia, and this is probably the best trial, which is New England Journal of Medicine, published in 2015, which showed there was no real benefit in therapeutic hypothermia in the pediatric range, which is different to what we think for neonates and again some adult studies. We would probably accept that glucose being slightly higher than normal, as we're aware of the dangers of trying to give insulin, causing hypoglycemia, and the impact that that can have on an already starved brain and body, essentially. In terms of precipitating pathophysiology, from my point of view, I want to try and identify what the etiology, so what made this patient arrest. And if I know that, I might be able to put some parameters in place in order to reduce the chance of that happening again. So I'm aware we've only got a few minutes left, so we're going to use 2 cases to really discuss about what we've talked about so far and put it into a little bit of practice. So 14-year-old collapse of football, shockable rhythm, and you've got Ross back after the 4th shock. So as mentioned before, our pathway for this patient is not just limited to the ED or ICU, but if they survive, it's a long process. And the median early intervention and intermediate will usually be done between ED and ICU. And the focus initially for that is to try and limit that ongoing injury and support the organs. And it's really only after about 72 hours we can start to prognosticate and think about rehabilitation and ensuring those services are in place for our pediatric patients. Underpinning all this is this preventing recurrence theme that sets the whole way through. So again, to reinforce this, I'm thinking about stabilizing, optimizing and packaging these patients. I'm thinking about the head, the heart, the general system, and also trying to decrease the chance of them go back into an arrhythmia. So I'm going to give you a few seconds. I just want you to really think about how you would prioritize these interventions. And I do strongly believe in an ABC approach, as it helps the team focus on where they're going and helps me remember what I need to do. So in terms of airway, while you're waiting for the team to arrive, you're thinking about securing it, making sure position is in the correct place. And if you haven't got a definitive airway, to put it in place. We've mentioned the importance of looking at the saturations in your CO2, and you'll have constant discussions with ICU and the transport team. You don't want to limit that transport, but if they're adamant they want an arterial line, if you can get that in place before the transport teams arrive, it will speed up the transfer and extradition of that patient. You want to be careful with your rate and the volume that you're using to resuscitate these patients, particularly if you haven't a huge amount of experience in these areas. Anecdotally, people will have a huge sum of adrenaline. They will start bagging at a higher rate and volume than required. This will result in distension of your lungs, decrease your vascular return, and decrease your cardiac output to the detriment of the patient. So think about putting them on a ventilator early. We've mentioned about looking after our perfusion, our blood pressure, our pulse. Vasoactive agents, as Chris mentioned, have early, and once you have successfully resuscitated them, you're redirecting your staff to try and get those agents ready early, and we would probably use adrenaline in our units and ensuring you get decent vascular and arterial access. From a D point of view, I'm thinking is there any neurology, so as well as the child arresting primarily probably from some sort of cardiac dysrhythmia, am I having any signs maybe think that there was concurrent head injury with promoted that arrhythmia, or trying to prognosticate things on blood sugar and making sure it's not low but accepting that's a little bit high, and keeping an eye on that temperature and targeting it as necessary. Multitasking is something that we do particularly well in the ED, which I'm proud to say. So communication is a key part of this. So as well as communicating with your team, you're also communicating with all your staff in your department, and you're communicating with parents, you're updating the transport team, and you're updating the unit that's receiving them. And that communication should go both ways, as well as giving them information. You're looking at information to come back to you as what you may need to do to that case. And use that time while you're waiting for the team to get things in place. So think about imaging, blood work. Do you require any other medications? And definitely getting symptoms, things like an ECG. There's very little medication you might think for these patients, but we know the post-cardiac arrest patients, up to about 30% of them will have a seizure. So if you've paralyzed them, if you don't have CFM on, you might not know what's happening. In that case, you have a low threshold for giving probably Keppra, as mentioned, but that will be done in discussion with your transport team and accepting units. And the key to me from AD is that my department doesn't allow me to focus on this one patient for an infinite amount of time. I have a sea full of essentially undifferentiated kids who can be in different periods of distress. As mentioned, all my resources are pulled into resus, so I need to restart to redeploy my staff to start looking after all those other cases, because those category 4 patients can quickly become a category 2 or 1 patient if they're left for a prolonged period of time. Think about your staff. So a huge amount of staff in the NHS is experiencing burnout, and events like these in overstretching on the resource departments just can make things worse. So look after them, make sure they're getting breaks, the time to clear their head before they get back to work. So case 2, we'll run through reasonably quickly. We're going to talk about a 10-year-old male road traffic accident who had an arrest downtime for about 10 minutes. Because there's a trauma, we changed our algorithm slightly. We give him some blood products. We've done bilateral thoracostomies, and we have got Ross back. So I want you to think initially about how does your post-resuscitative care for a trauma patient differ from your medical one, or is there a difference? I would argue there's not a huge amount of evidence out there, but from my point of view, there isn't really, in that we're still going for these same parameters, thinking about the head, the heart, the body, and trying to prevent them re-arresting. And how we approach this differs because our resuscitation algorithm differs, and the reason why they've arrested will differ, but the same ABCD principles still are at play. About 40% of traumatic cardiac arrests are a consequence of hypovolemia due to bleeding. So think about where that bleeding may have come from. If you've got an obvious bleeding source, try and reduce that either by putting some pressure on it, and by using tourniquets, pressure dressings, or clotting. From an airway, thinking about C-spine injuries, and we talked about collars and their use, blocks and tapes, in my point of view, are an excellent means to do this. But you need to consider this early. As you've got a C-spine injury that's not been addressed, your consequences can be dire. As well as doing our normal breathing activities, if this patient has responded to bilateral thoracostomies, which is essentially putting 2 holes in the chest to let some air and blood out, you're going to need to formally insert chest drains so that the patient is ready for transport. So who is able to do this and how you're able to check that in the right place. Blood pressure and cap refill we've mentioned, and even more importantly, I do not want my trauma patient to be hypotensive. I want to be aiming towards at least the 50th centile, and if there's a coexistent head injury, I'm going to be aiming for a little bit higher to try and perfuse the head, but also if I'm worried about a spinal injury, I don't want it being getting under-perfused either. Thinking about activating my major hemorrhage protocol, but given tranexamic acid, access is already mentioned. Blood sugar is really important, neurology from head injury, and then temperature is even more important. I do not want my trauma patient cold. We know that being cold is part of our deadly triad of trauma, so I'm actively trying to get these patients back into normal thermia. Hemorrhage control, I might be putting a pelvic binder on if it's not on already, and neuroprotection, as we mentioned, for traumatic brain injury needs to be considered and implemented. And before the transport team arrive, I want the patient to get through a CT scanner. For the likes of this patient, you won't be ordering a pan scan, but essentially for all purposes it is head, neck, chest, abdomen, pelvis, in order to identify any injuries that need addressed. Now this will give you a huge amount of information that you can then pass on to not only the receiving area, so that they've got the correct people there to initiate immediate life-saving interventions, but also from your department if there's anything that you need to do before the patient is transported. Again, from these point of views, you're thinking of the simple things that need to be done well. So if you're involved in traumatic cardiac arrest, there's generally blood and material all over the place. It takes time for this to be cleaned and restocked for the next patient. These events can have a huge impact on your department. So you're thinking about your hot and your cold debrief. And then you're also thinking about any learning, because there's such rare events. If there are learning, you want to get it in place for the next one happening. And in pediatrics, we always think of prevention. So is this another stabbing injury? Is a road traffic accident in the same area? Is there an intervention we can put in place to try and prevent this happening again? So many thanks for giving me the opportunity to talk through my approach to post ROSC patients and what we need to do from an emergency department in order to stabilize them from transfer. So code is at the bottom. Any feedback is greatly appreciated. And if you have any questions, we're happy to answer. And thank you for listening.